This talk is simply my approach to bedside ultrasound for appendicitis. I thought I'd put these slides up after watching an excellent talk by Dr. Levine, which gives a great overview of the background and evidence behind bedside ultrasound. Can I suggest you have a look at this video when you get the chance? My own talk simply describes an approach with more pictures as to how I go about finding the appendix. Start with a bit of background though. We look at the traditional paradigm which suggested that appendicitis, which used to be called a catarrhal appendix by the pathologists, was probably triggered by an obstructing fecalith, was thought that it might resolve if the fecalith was extruded, and gave symptomatology of a gradual increase in pain. As the walls became edematous, they became more distinct on ultrasound, giving them a stripy look, and if untreated, it was thought that the walls would become ischemic, the bacteria would translocate across the walls, we lose the distinct wall layers and progress eventually to perforation. However, there are alternative theories, many alternative theories. One is that there is a completely separate process that can result in an acutely and rapidly gangrenous appendix, perhaps related to an overenthusiastic metalloproteinase response, resulting in venous thrombosis in the mesentery. This might explain the patients with pain out of proportion to clinical signs and laboratory signs, and explains the patients who present and perforate within 24 hours. The reason I point this out is it looks quite different on ultrasound. There are many other hypotheses around appendicitis. An infectious agent is something we all suspect because of the way one tends to get clusters of appendicitis in time. There are also views that it's related to hygiene and diet. There are certainly occasional traumatic appendicitis. There are perhaps genetic predispositions, certainly foreign bodies including helminths and worms, and even a view that it might be, in some cases, a type 1 hypersensitivity. However, background aside, I think anyone who wants to do scanning for appendicitis should have at least a plan of attack, have a protocol, know what constitutes abnormal, and finally to standardize the reporting. For a plan of attack, particularly someone who lives in the emergency department doesn't necessarily have half an hour, we would perhaps suggest you start at the tender spot and look first up for an inflamed appendix. You might just get lucky. We recommend the patient is supine, perhaps with the right leg crossed over the left. However, if the appendix doesn't immediately jump out at you, you should then look for supporting findings or signs of inflammation. These may in fact be more sensitive than finding an abnormal appendix. If there are no supporting signs, you then have to use some sort of search strategy and attempt to locate a normal appendix. If you're still unsuccessful and still have more time in your busy emergency department, is useful to look briefly at the gallbladder, the right kidney, perhaps at bowel wall and at the pelvis. So if you can't find an immediately inflamed appendix, it's good to have a search strategy. One that I heard at the ASA conference a couple of years ago by Roger Gent seemed the most authoritative. I myself like to use a curved probe for the overview and then move to the straight probe to areas of suspicion. However, Roger Gent recommends the microconvex probe. He suggests that you start very low in transverse on the iliac artery, move rostrally up the iliac artery until you see the first portion of small bowel crossing across the iliac artery, which should be the terminal ileum. This joins a fluffy white cloud of cecum, usually just to the your left of the iliac artery. At this point, the appendix may be located. It is at the junction of the linea, is it haustra, at the bottom of the cecum. In any case, at this point it's good to rotate 360 degrees because of course the appendix can lie in any direction. Using graded compression may push some of the gas out of the way. If you haven't found the appendix after tracking all the way up the iliac artery, he suggests you then turn in longitudinal and track back down. If you still haven't found anything obviously appendix-ish, you can move laterally and try and push the cecum aside and finally look in the pelvis. Remember, a normal appendix that's not distended is often serpiginous, meaning that it's very hard to get it in a single longitudinal view. Usually you'll see several cross sections, partially oblique, partially longitudinal, in a cluster. It's somewhat similar to a vaginal stripe. There is often a very faint white line in the middle or white spot in the middle of an appendix. You'll rarely see it as clearly as this. To identify formally an appendix, you must show that it is a tubular structure. You must show that it is blind ending by sliding off the end of the appendix. You must show that it's actually nearly circular in cross-section, that it has no peristalsis. You can be fooled, for example, by a loop of ilium, which on our left portion of the slide looks like a blind ending tube. However, in cross-section, it's shown that it's actually not circular, but oblong in cross-section. So this is why you must demonstrate the appendix in two planes. Nothing else is small and round in cross-section like this. Now, showing a normal appendix is hard. Most people look first for that tiny spot of intraluminal air. And as I said before, it can be very hard to follow to the end, but since appendicitis may manifest just in the tip of the appendix, it is important that you run right off the end of the tube. Here is a couple of examples of the tiny little intraluminal spot of air and what it may look like in cross-section. The third step is that you know what actually constitutes appendicitis. There's a recent review by Trout that puts this into contention, but the original characteristics were described, believe it or not, in 1986, and very little has changed since then. It's very important that the structure you're proposing as the appendix is tender. Pilot, have you pronounced that name, described the diameter that had to be 6 millimeters or greater from outer wall to outer wall. It should be non-compressible. I would add that the increase in the diameter should be due to wall thickening rather than luminal contents. There is a condition called a mucocele of the appendix which gives a distended appendix but is more compressible and less tender. You should be measuring the diameter AP during compression. It's very useful if you can actually include pictures side by side showing the compression. And again, mind you, this one I've measured it incorrectly. It's nice if you can show a luminal fecalith, but this is by no means a consistent finding appendicitis. And you must beware when an appendix becomes gangrenous, the walls become quite indistinct. It does become very tender at this stage, but if you're looking for that stripy or target lesion, you'll be very disappointed. Note the small pocket of free fluid often at acts as a pointer to the end of the appendix. Here is an example of a very necrotic and gangrenous appendix, quite indistinct. And here is a picture of an appendix where it's the intraluminal contents that have resulted in the increased size. This one was actually normal at histology. Some people say that it's the supporting signs of inflammation that are more sensitive and useful predictors of appendicitis, perhaps less so in adults and adult women. Suspicious findings include echogenic or bright fat just next to the appendix, small pockets of free fluid, increased vascularity adjacent, although I find this hard to demonstrate with low-end bedside machines. I do think an area of adjacent ileus or an indistinct mass is a useful sign. Sometimes you spend your time looking for a tiny appendix and you miss the great collection beside it. And also prominent lymph nodes. But it's important to remember that lymph nodes may be an effect of the appendiceal inflammation, or they may be a separate cause. They're certainly not specific. So bright fat looks like this. It's more obvious with compression. It gives rise to what we used to call thyroid in the abdomen. The bright fat compressed around the gangrenous appendix. These small pockets of free fluid can be quite useful arrows towards the appendix, but of course may be fluid tracking up from a ruptured ovarian cyst, so I like to compare it with the amount of fluid in the pouch of Douglas. Areas of adjacent ileus can be useful signs, as is suspicious indistinct masses and collections. And as I said before, sometimes a scout with a curved probe to show you the big picture can be more useful, particularly when there's a lot of gas around. Sometimes you'll find an indistinct round mass, but if you look at 90 degrees, you'll find it remains an indistinct round mass. These can be quite prominent lymph nodes. If you power Doppler on, you can often show a feeder vessel. You may also find colitis. It's very important to recognize surrounding inflammation. Segments of bowel with one wall greater than 4 millimeters. At least this is the measurement I use on the bedside machines. With the high-end machines, you could perhaps use greater than 3 millimeters. This is something that tends to stand out at you, either as a black donut in the abdomen or long tram tracks. You try and ascertain a rough distribution, whether it's in the region of a particular blood vessel or whether it's an area of localized tenderness. It might perhaps be sigmoid diverticulitis or terminal ileitis. I do think, finally, that it's important to standardize reporting. I feel that a lot of the variability we have in sensitivity and specificity of bedside ultrasound is a result of us not being clear in what we are finding. My personal preference is that if I can see an abnormal appendix, then I will say so, and this is a very specific finding. If there are supporting signs, but I haven't formally identified the appendix in two planes, then I'll say that's suspicious. If there are no findings either way, we need to be definite on this. If I have been lucky enough to find a normal appendix, I'll say so judiciously, and if I've found an alternative cause. But the bottom line, I have to say, is that the most useful thing about this procedure is that you spend a bit of time with the patient. You lay hands on and talk to them, you examine them thoroughly, and you take time to do this. Even if you never get a glimpse of the appendix, by the time you finish 10 or 15 minutes later, you have a far better idea of what is going on with this patient. Thank you.